Hello, everyone. Today we will be discussing the Achenbach system of empirically based assessment, also known as the ASEBA, for school-aged children and adolescents, as well as adults. So what is the ASEBA? The ASEBA is a collection of tools designed to assess a wide range of emotional, behavioral, and social problems across the lifespan, from early childhood to late adulthood. There are different tools for different age groups, and the ones we will be looking further into today are the school age forms for children aged 6 to 18 and the adults aged 18 to 59. Both include a family of forms, which allows for consistent evaluation of individuals across different informants to facilitate the identification of issues, planning of interventions, and monitoring of outcomes in clinical settings. The ASEBA forms were developed by Dr. Achenbach and Dr. Rescorla. Specifically, the school age forms were published in 2001 and the adult forms not long after in 2003. So this is just an overview of the family of forms we touched on earlier. We have different forms tailored for various age groups and respondents. For school-aged children, there are 3 forms. We use the Child Behavior Checklist, or CBCL, the Teacher's Report Form, or the TRF, and the Youth Self-Report, or the YSR. For adults, there are 2 forms, the Adult Self-Report and the Adult Behavior Checklist, or the ACR and the ABCL. And we will get into the details of each of these throughout the presentation. Moving on to the purpose of development. The ASEBA was first developed to identify patterns of problems in children and adolescents. Over a period of 30 years, a family of instruments has been developed to assess problems and competencies in school-aged children and adolescents from the perspectives of parents, teachers, youth, clinical interviewers, and observers. This came at a time when the first version of the DSM provided only 2 diagnostic categories for child psychopathology. In the initial research, behavioral and emotional problems were scored from a large sample of child psychiatric case records. Factor analyses revealed several patterns of syndromes that were not identified in the DSM. Syndromes to the researchers meaning problems that tend to co-occur, with no assumptions about the cause of the problems or their co-occurrence. To obtain samples of data not subject to possible selectivity for psychiatric case records, they developed the Child Behavior Checklist for completion by parents who usually have the most comprehensive knowledge of their children's functioning. The CBCL was then tested and revised through many pilot editions using both clinical and general population samples, then multi-informant approaches followed. To meet the research needs of their long-term follow-up studies, Achenbach and Rescorla developed the tools for assessing young adults aged 18 to 30, which were the Young Adult Self-Report and the Young Adult Behavior Checklist. These forms underwent revisions to integrate the latest research findings from the researchers' 1999 National Survey of Children, Youth, and Adults to obtain normative data for ages 1.5 to 90 plus, as well as updated diagnostic criteria and valuable user feedback. Thus, the ASR and ABCL were born. These changes were aimed at refining the tool's effectiveness and ensuring their relevance in the face of evolving scientific and clinical understandings of adult psychopathology, not just for young adults. First, let's dive into the purpose of use for the ASEBA, which we touched on before, is a collection of standardized tools that can be specifically used for assessing competencies, adaptive functioning, and problems in school-age youth as well as adults. The ASEBA suite of tools is utilized by multiple informants to capture a broad and nuanced picture of an individual's functioning. These include self-reports through the YSR and ASR, allowing individuals to provide personal insights into their own emotional and behavioral states, parent reports via the CBCL, which gather parental observations and concerns about their child's behavior and emotional well-being, teacher reports through the TRF, offering an educational perspective on a child's academic performance and social behaviors. And lastly, informant reports for adults using the ABCL, where someone who knows the adult well, like a partner or a close friend, can provide context on the adult's behavior. Additionally, the ASEBA's versatility as a practical assessment tool extends across various settings, such as mental health, medical, school, and forensic settings, and research topics. Looking closely at its use in clinical settings, ASEBA instruments can be used at many stages of clinical processes, including screening to identify needs for help, documentation of problems, and adaptive functioning for use in clinical referrals, and intake assessment on which to base treatment decisions. During the course of treatment, they are useful for determining whether goals are being met, and following treatment, ASEBA instruments can be re-administered to evaluate outcomes and subsequent functioning. At any point, ASEBA instruments can be used to assess behavioral, emotional, and social factors of neuropsychological and medical disorders. The availability of similar instruments for children and adults can also facilitate family assessment, as well as close coordination between interventions for parents and their children. It's very important to note that the ASEBA is designed to provide standardized descriptions of functioning, so no scores on scales should be equated with a particular diagnosis or disorder. It is meant to be integrated with other types of data to provide comprehensive evaluations of functioning. Let's now focus on the ASEBA forms specifically designed for school-aged children and adolescents ages 6 to 18. Again, there are three forms. First, the CBCL, which is completed by parents and evaluates a wide spectrum of emotional and behavioral problems alongside competencies in everyday activities and academics. This tool is invaluable across various settings, assisting in everything from clinical diagnoses to educational interventions. Then we have the YSR, which allows children ages 11 to 18 to provide their own perspective on their emotional and behavioral difficulties, as well as their social skills. This self-assessment fosters self-awareness and ensures that the child's voice is central in their care process. Lastly, the TRF, which is filled out by educational professionals, focuses on the child's academic performance, group interactions, and overall behavior in school settings. It offers a crucial educational perspective and highlights issues that may not be apparent in home or clinical environments. Moving on to the adult forms. These forms cover the age range of 18 to 59 years and are designed to comprehensively assess adult psychopathology and adaptive functioning in various life contexts, which helps enhance our understanding of intervention strategies. The ASR is completed by adults themselves, providing personal insights into their own psychological health and adaptive capabilities. It's instrumental in areas such as employment, social relationships, and personal well-being, reflecting how adults navigate their environment and manage psychological challenges. Additionally, we have the ABCL, which is filled out by somebody who knows the adult well, like a partner, sibling, or friend. This informant's perspective offers a unique vantage point, often revealing behavioral and emotional issues that may not be apparent to the individual themselves or in a clinical setting alone.
Now moving on to the essential elements in ASEBA's test construction. First with the items for the school age forms. The child behavior checklist, also known as the CBCL, contains 113 items and is typically completed by parents or guardians to evaluate their child's behavior at home. The teacher's report form, TRF, includes 120 items and is filled out by teachers to provide insights into the child's behavior in a school setting. It's also important to note that not all of the TRF uses a 3-point scale. Some sections have different response formats to capture specific information from educators. And lastly, the youth self-report YSR consists of 112 items and is completed by the youth themselves between the ages of 11 and 18, allowing them to self-report on their behaviors and feelings. Most items on these forms use a 3-point scale for response options. 0 is not true as far as you know. 1 is somewhat or sometimes true, and 2 is very true or often true. And each form typically takes about 15 to 20 minutes to complete, and respondents should have approximately a grade 5 reading level to understand and accurately respond to the items. The user or administrator of these assessments is recommended to hold at least a master's degree or 2 years of residency in psychiatry or family practice to ensure proper interpretation and application of the results. And regarding administration, like mentioned prior, the forms can be self-administered or informant administered, depending on who is completing them. They are available in various formats, including paper and pencil, digital and online, what Chris and I did, and there are also software-based scoring options, providing flexibility to suit different settings and preferences. Importantly, if a respondent has difficulty completing a form, perhaps due to reading challenges or language barriers, the form can be read aloud by an interviewer who then records the respondent's answers. Diving deeper into the ASEBA scales, starting with the competence scales, which are included in the CBCL and YSR only. These scales assess areas such as activity, social involvement, and school performance, and together they contribute to a total competence score. Also important to note that the school competence scale is exclusive to the CBCL. And altogether, these scales help us understand how children and adolescents are functioning in everyday life beyond just their behavioral or emotional problems. Next, we have the syndrome scales consisting of 8 distinct categories: anxious and depressed, withdrawn and depressed, somatic complaints, social problems, thought problems, attention problems, aggressive behavior, and rule-breaking behavior. These syndrome scales are crucial for identifying specific patterns of behavior and emotion problems. You might notice that there are I's and E's by some of them. The internalizing problems indicated by an I reflect inward-focused behaviors like anxiety and depression, while the externalizing problems marked as E represent outward-directed behaviors such as aggression and rule-breaking. In addition to the syndrome scales, there are also 6 DSM-oriented scales that align with diagnostic categories from the DSM: affective problems, anxiety problems, somatic problems, oppositional defiant problems, ADHD, and conduct problems. And these DSM-oriented scales aid clinicians in identifying symptoms that correspond with DSM diagnoses, facilitating a more seamless integration of assessment results into treatment planning. The teacher's report form, the TRF, also includes an adaptive functioning profile, which assesses areas like academic performance and overall adaptive functioning in the school environment. This information is very important for understanding how a child is coping and performing in educational settings from a teacher's perspective. It's also important to note that all forms, the CBCL, TRF, and YSR, are scored for total problems and include critical items that may indicate serious issues requiring immediate attention for the clinician to further explore. Onto elements of the adult forms. We see many similarities with the school-aged elements, but of course different forms. Both the adult self-report ASR and the adult behavior checklist ABCL contain 126 items each, which are designed to capture a wide range of behaviors and emotions, resulting in a comprehensive assessment through a total of 24 scales, which we will go through in the next slide. The response options for these items are the same based on a 3-point scale. And in terms of time and user qualifications, each form typically takes about 10 to 20 minutes to complete. Same with the school age forms. Respondents should have approximately a grade 5 reading level to understand and accurately answer the questions. And the administration and interpretation of these assessments should be conducted by a professional with at least a master's degree or 2 years of psychiatric experience. The forms are available in the same formats as the school age forms, including paper and pencil, digital and online, and software-based scoring options. Onto the adult scales, starting with the adaptive functioning scales. There are 6 key areas assessed: friends, spouse and partner, family, job, education, and personal strengths. It's important to note that the scales marked with an asterisk here, family, job, education, and personal strengths, are included in the self-report form only. These scales provide insight into how adults perceive their functioning in various aspects of their life, such as relationships, employment, and personal abilities. And next we have the syndrome scales, which consists of 8 categories: anxious and depressed, withdrawn, somatic complaints, thought problems, attention problems, aggressive behavior, rule-breaking behavior, and intrusive behavior. Again, the syndromes labeled with an I indicate internalizing problems, and those marked with an E mark externalizing problems, which are 2 broadband scales that combine the syndrome scales. But all in all, these scales help identify specific patterns of behavior and emotional difficulties in adults. In addition, there are also 6 DSM-oriented scales that align with diagnostic categories from the DSM-4: depressive problems, anxiety problems, somatic problems, avoidant personality problems, ADHD problems, and antisocial personality problems. And these scales assist clinicians in identifying symptoms that correspond with DSM diagnoses, facilitating accurate assessment and effective treatment planning. Furthermore, the assessment includes substance use scales covering 4 areas: tobacco use, alcohol use, drug use, and mean substance use. And these scales evaluate the individual's use of various substances, which is crucial for understanding and addressing issues related to substance use. Both the ASR and ABCL forms are scored for total problems and include critical items that may indicate serious concerns requiring immediate attention. Next is the text test construction of the DSM-oriented scales within the ASEBA. We went over these prior, but just wanted to point out some differences. We can see here affective problems in children versus depressive problems in adults, as well as conduct problems versus oppositional defiant and avoidant personality versus antisocial personality. The differences in scales between these age groups exist because psychological problems often manifest differently across developmental stages, and certain disorders are more prevalent or relevant in specific age groups due to developmental, psychological, and social factors. For instance, the DSM outlines different criteria for disorders based on age. For instance, conduct disorder is diagnosed before age 18, while persistent antisocial behavior after 18 may be diagnosed as antisocial personality disorder. In regards to expert ratings, the development of these scales involve extensive input from professionals across various cultures to ensure validity and cultural relevance. For school-aged forms, 22 psychiatrists and psychologists from 16 different cultures rated the items, and similarly for the adult forms, 21 psychiatrists and psychologists from 10 cultures participated in the rating process. In the process of grouping items, only those items that were rated as very consistent with DSM criteria were included in the DSM-oriented scales. This selection ensured that these scales were highly specific and relevant to the diagnostic categories they represent. The result is a set of scales that provide clinicians with reliable tools for assessing symptoms aligned with DSM diagnoses, thereby facilitating accurate assessment and effective treatment planning. Onto profiles of the DSM-oriented scales. Starting with the scoring system, each item on the DSM-oriented scales is rated using a 0, 1 to 2 scale, 0 meaning not true, 1 meaning somewhat or sometimes true, and 2 is very often or often very true or often true. These ratings are then summed for each scale, resulting in a total score for each DSM-oriented scale. Higher scores indicate a greater consistency with the DSM diagnostic categories, suggesting that the individual symptoms more closely align with the criteria for specific mental health disorders as outlined in the DSM. When it comes to interpretation, the profiles display these scores in a way that differentiates between normal, borderline, and clinical ranges. This differentiation is instrumental in helping clinicians identify cases of concern, and scores falling into the borderline or clinical ranges may indicate that the individual requires further evaluation or intervention. However, it's important to acknowledge the limitations of these scales. Firstly, scores do not equate to a DSM diagnosis. While higher scores suggest a greater alignment with DSM criteria, they are not sufficient on their own to make a formal diagnosis. Secondly, the items included in these scales do not cover all the criteria required for a DSM diagnosis. They're just designed to screen for potential problems rather than provide a comprehensive diagnostic evaluation. Looking into more elements of the DSM-oriented scale, starting with the severity of problems, the DSM-oriented scales are essential tools that allow clinicians to track changes in a client's condition over time, particularly in response to interventions. By administering these scales at different points during treatment, we can monitor shifts in symptom severity. Declining scores on these scales may indicate potential improvements in the client's condition, suggesting that interventions are effective. This quantitative tracking is really important for evaluating treatment outcomes and making necessary adjustments to the therapeutic approach. For considerations for high scores, it's important to note that high scores across multiple DSM-oriented scales may indicate comorbid disorders. By examining patterns in the profiles, clinicians can identify overlapping conditions or unique clusters of problems, which assists in developing comprehensive treatment plans that address all areas of concern, rather than focusing on a single disorder. Regarding computerized profiles and cross-informant comparisons, the ASEBA modules for both ages 6 to 18 and 18 to 59 facilitate computerized scoring and comparisons. This technology allows for efficient data processing and generates visual representations of the results. Side-by-side graphs of the ASEBA forms enable clinicians to compare different informant's ratings, such as those from self-reports, parents, teachers, or close acquaintances. By detecting cross-informant similarities, we can confirm consistent patterns of behavior across different settings and perspectives, which enhances the reliability of our assessments. However, we must also consider cross-informant differences. Variations between informants' ratings may reflect situational differences in behavior or environmental influences. For instance, an individual might display certain behaviors at home that are not evident at school or work. So these discrepancies highlight the need for a comprehensive evaluation of the client, taking into account multiple environments and contexts. Understanding these differences is crucial for developing a well-rounded understanding of the client's functioning and for tailoring interventions accordingly. Also, touching on items specific to self-report and observational scales, it's important to recognize that some aspects of an individual's experience can only be accurately reported by themselves, while others are best observed by someone else. And I'll briefly highlight examples from both the school-age and adult assessments. For school-aged individuals, the YSR captures internal experiences that may not be observable to others. For instance, items like I feel worthless or inferior, or I think about killing myself, reflect critical personal thoughts and feelings that only the individual can report. These critical items are crucial for identifying internalizing problems that might otherwise go unnoticed. Conversely, the TRF includes observations that can only be made in a school setting. For example, a teacher might note that a student breaks school rules or disturbs other people's, and these behaviors are often specific to the classroom environment and may not be observed by parents or the students themselves. Additionally, the TRF captures hyperactivity indicators important for informing about ADHD, which are not included in the CBCL or YSR. So in the case of adults, the adult self-report ASR includes items reflecting personal emotions and self-perceptions, such as I feel sad or I have poor self-image. These internal states are best reported by the individuals themselves as they pertain to subjective experiences. On the other hand, the ABCL, completed by someone who knows the adult well, emphasizes interpersonal difficulties that might be more evident to others. For example, an informant might report that the individual is controlling or feels misunderstood, highlighting patterns in relationships that the individual may not recognize. Okay, looking closer at the critical items on both adult forms, this table here lists 19 items that were identified by more than 13 international psychologists and psychiatrist raters as definitely critical. Each of these items is really important to consider in its own right, even if it is not included in a DSM-oriented scale. To make it easy for users to quickly spot a client score for each critical item, the computer software for the ASR and ABCL prints a list of the critical items with the client score for each item. The software also displays a sum of 0, 1 to 2 scores on the 19 critical items as a bar graph in relation to T-scores and percentiles for the US national normative sample. It's important to note for the school age forms, similar, but there's no specific or separate critical items list. But the narrative reports display ratings for critical items that are of particular clinical concern for each child based on items on the YSR, TRF, and CBCL.
All right, now that we've covered the general overview of the ASEBA and its applications in assessing youth behavioral and emotional functioning, I'd like to shift our focus to an essential aspect of any assessment tool, and that is its reliability. To start, let's look at the inter-interviewer reliability. This type of reliability checks whether different interviewers obtain similar scores when they administer the ASEBA to different groups of children. To assess inter-interviewer reliability, the authors compared the CBCL scores obtained by 3 different interviewers from a home interview survey. Each interviewer assessed a matched group of 241 children, ensuring that socio-demographic factors were consistent across groups. This method prevented any confounding factors that could arise from having the same respondents assessed by multiple interviewers simultaneously. The results were highly promising. For the 20 competence items, the ICC value was 0.93, and for the 118 specific syndrome items, the ICC was 0.96. Both of these values were statistically significant, indicating that there is a very high inter-interviewer reliability. In practical terms, this means that different interviewers administering the CBCL are likely to obtain nearly identical scores, ensuring that the assessment is dependable regardless of who conducts it. Next, let's discuss test-retest reliability, which measures the consistency of scores over time. To evaluate this, The authors conducted a study where a single interviewer administered the CBCL to mothers of 72 non-referred children, with a 1-week interval between assessments. Moving forward, let's examine the test-retest reliability of the ASEBA scale scores. Test-retest reliability assesses the stability of scores over time, indicating whether the assessment produces consistent results when administered to the same individuals under similar conditions on different occasions. To evaluate test-retest reliability, the authors computed Pearson's correlation coefficients and conducted t-tests between CBCL ratings by parents, YSR ratings by youth, and TRF ratings by teachers at mean intervals of 8 to 16 days apart. This approach helped the authors understand both the consistency in rank ordering and the magnitude of scores over time. These high correlation coefficients indicate that the ASEBA scale produces stable and consistent scores over short intervals. Next, let's examine the stability of scale scores across longer periods, Moving forward, let's examine the test-retest reliability of the ASEBA scale scores. Test-retest reliability assesses the stability of scores over time, indicating whether the assessment produces consistent results when administered to the same individuals under similar conditions on different occasions. To evaluate test-retest reliability, the authors computed Pearson's correlation coefficients and conducted t-tests between CBCL ratings by parents, YSR ratings by youth, and TRF ratings by teachers at mean intervals of 8 to 16 days apart. This approach helped the authors understand both the consistency in rank ordering and the magnitude of scores over time. These high correlation coefficients indicate that the ASEBA scale produces stable and consistent scores over short intervals, influenced by immediate classroom dynamics or interventions. Moving on to internal consistency, this aspect measures how well the items within a scale are related to each other. We can see here that the DSM-oriented scales exhibit good to excellent internal consistency, ensuring that these scales reliably align with DSM diagnostic categories. For the syndrome scales, these high alpha values indicate strong internal consistency, meaning that the items within each problem scale are well correlated and effectively measure specific behavioral and emotional issues. The only exceptions were a few scales with alphas below 0.75, such as the withdrawn or depressed and the social problem syndromes, as well as the TRF somatic complaints and thought problem syndromes. These lower alphas can be attributed to items that are rarely endorsed by teachers, potentially reflecting the context-specific nature of certain behaviors. Regarding the competence scales, these alphas are quite respectable, especially considering that some scales have as few as 4 items, such as the CBCL school scale. Despite the relatively small number of items, the competence scales demonstrate moderate to high internal consistency, reflecting their ability to reliably measure various competencies like activities, social involvement, and school performance. However, it's crucial to balance internal consistency with the diversity of items. A very high alpha might suggest redundancy among items, while a lower alpha might indicate that the scale is capturing a broader, more nuanced construct. Next, we'll discuss cross-informant agreement, which examines the consistency of scores across different informants, such as parents, teachers, and the individuals themselves. Cross-informant agreement is crucial for obtaining a comprehensive and multifaceted view of an individual's functioning. So there are 3 kind of key observations that I want to quickly point out. The first being parents reporting on parents. There's a high agreement, so a mean R of 0.6 to 0.76, suggesting that mothers and fathers have similar perceptions of their child's competencies and problems. Regarding teachers reporting on teachers, there's a moderate agreement, indicating some consistency, but also variability in teachers' assessments. And lastly, regarding mixed informant combinations, there seems to be quite a low agreement, around 0.2 to 0.5, which highlights differences in perspectives between parents, teachers, and youth. For example, when the CBCL is compared to YSR on the competence scale, it shows a mean R of 0.54, reflecting a moderate agreement between parents and youths in assessing competencies. Conversely, when the YSR is compared to the TRF, On the syndrome scales, it had a mean R of only zero point 0.2, which indicates poor agreement between youth and teachers in identifying behavioral problems. The differences in cross-informant agreement underscore the importance of attaining multiple perspectives when assessing an individual's behavior and emotional state. For instance, a child might exhibit different behaviors at home and at school, leading to discrepancies between parent and teacher reports. Ultimately, these differences highlight the need for a comprehensive evaluation that takes into account various environmental contexts and informant perspectives. To evaluate the test-retest reliability of the ASR and ABCL scales, the authors compared ratings obtained on two separate occasions, approximately 7 days apart. The reliability findings were generally very high, indicating that the ASEBA scales exhibit excellent test-retest reliability, and this means that the ASR and ABCL are highly consistent over short intervals. Next, let's explore the internal consistency of the ASEBA scale scores for adults. The internal consistency values for the ASEBA scales indicate that, overall, the items within each scale are coherently measuring the intended constructs. However, the lower alphas in certain scales, such as the ASR thought problems and anxiety problems, highlight areas where the scales may benefit from further refinement to enhance internal consistency without compromising the breadth of the construct being measured. Moving forward, let's examine cross-informant agreement for adults. There are just 3 observations that I want to highlight here regarding high, moderate, and low agreement scales. So first off, the tobacco scale showed a high cross-informant correlation of 0.79, suggesting strong agreement between self-reports and informant reports regarding tobacco use. Most other scales, particularly the empirically based and DSM-oriented problem scales, showed moderate to fair agreement with mean R values of 0.4 and 0.38 respectively. The thought problem syndrome had the lowest correlation of 0.3, indicating poor agreement between self-reports and informant reports for this specific issue. The difference in cross-informant agreement highlights the importance of obtaining multiple perspectives when assessing an individual's behavior and emotional states. Again, for example, an adult might exhibit certain behaviors at work that are not evident to a spouse, or might experience internal emotional states that informants are unaware of. Continuing our discussion on the psychometric properties of the ASEBA, let's now dive into content validity. Content validity is foundational to any assessment tool, as it ensures that the instrument accurately represents the constructs it intends to measure. The development of ASEBA items has been a meticulous process spanning several decades. Starting in the 1960s, ASEBA problem items were developed and refined based on extensive research and practical experience. The development and refinement of competence items began in the 1970s. This involved identifying and measuring various competencies such as social involvement, academic performance, and daily activities. The selection of items for the CBCL, YSR, and TRF involved comprehensive literature reviews, consultations with mental health professionals and special educators, and pilot testing with parents, youth, and teachers. These procedures ensured that the items were both relevant and effective in capturing the intended constructs. Current evidence supports that all items can significantly discriminate between demographically similar referred and non-referred children. Moving beyond content validity, let's examine criterion validity, which assesses the degree of association between ASEBA scale scores and external criteria relevant to the constructs being measured. To investigate the associations between referral status, demographic variables, and ASEBA scale scores, the study employed a structural equation modeling, or SEM, approach. The analyses revealed that referral status had a significantly larger impact on scale scores compared to demographic variables. And while SES showed more significant associations with competence and adaptive functioning scales than to age or ethnicity, all demographic effects were small. The strong associations between referral status and ASEBA scale scores affirm the criterion validity of the ASEBA instruments. This means that the ASEBA scales are effective tools in identifying and differentiating children who require mental health or special education services from those who do not. As we continue our comprehensive exploration of the ASEBA psychometric properties, it is essential to address construct validity. Construct validity refers to the extent to which a scale accurately measures the theoretical construct it is intended to assess. For the ASEBA, this involves ensuring that each syndrome scale effectively represents the underlying behavioral, emotional, and social constructs it aims to measure. One of the strongest pieces of evidence for the construct validity of ASEBA scales come from their correlations with DSM diagnostic criteria. For example, ADHD, the ASEBA's empirically based attention problem syndrome and DSM-oriented ADH problem scale both correlate highly with ADHD diagnoses. This indicates that ASEBA scales effectively capture the construct of attention problems as defined by the DSM. Empirically based rule-breaking behavior and DSM-oriented conduct problems scales correlate significantly with DSM checklist conduct disorder scores. Similarly, aggressive behavioral syndrome and DSM-oriented oppositional defiant problem scale correlate with DSM checklist ODD scores. To further validate the construct validity, the authors examined the associations between ASEBA scale scores and clinical diagnoses. These kappa coefficients, all significant, demonstrate meaningful associations between ASEBA scale and clinical diagnoses, supporting the construct validity of the ASEBA instruments. Construct validity is further supported by strong correlations between ASEBA scales and other established behavioral assessment tools, such as Connor Scale and the BASC. Longitudinal research provides compelling evidence for the construct validity of ASEBA scales by demonstrating that early ASEBA scores predict later behavioral and emotional outcomes. Early ASEBA scores predict adult outcomes such as substance abuse, legal troubles, suicidal behavioral, and continued mental health referrals. Moving on to the adult section of validity, we will start with content validity. The ASR and ABCL problem items have undergone a rigorous and iterative development process. Starting in the 1960s, ASEBA problem items were meticulously developed based on extensive literature reviews, consultations with mental health professionals, and practical experience. All problem items in the current ASR and ABCL were retained based on their ability to significantly discriminate between referred adults and demographically similar non-referred adults. This discrimination was achieved through empirical loading and expert consensus. Empirical loading means that items loaded significantly on empirically derived syndromes, whereas expert consensus means that items were reviewed and confirmed by expert panels for consistency with DSM-4 diagnostic categories. Adaptive functioning items assess positive aspects of behavior and skills necessary for successful adaptation in various life domains. Longitudinal research provides compelling evidence for the construct validity of ASEBA scales by demonstrating that early ASEBA scores predict later behavioral and emotional outcomes. In a 3-year predictive study in an American sample, YSR syndrome scales predicted YASR scores 3 years later, with a mean correlation of 0.48. This indicates that adolescent behavioral and emotional assessments are moderately predictive of young adult functioning. In another 10-year predictive study in a Dutch sample, YSR scores at ages 11 to 19 significantly predicted YASR scores and DSM diagnoses even 10 years later. YASR syndromes were most strongly predicted by their YSR counterparts, demonstrating the stability and long-term predictive power of ASEBA scales.
So on to clinical and diversity considerations of the ASEBA. The ASEBA is great for multicultural applications because it's broad spectrum of specific problem items that can be rated by different informants without specialized training. For instance, the module with multicultural options allows users to compare scale scores for children and youths and also adults on the CBCL 6 to 18, TRF, YSR, ABCL, and ASR to norms for user-selected societies. And these modules use multicultural norms that are based on ratings from thousands of children, youth, and adults in over 50 societies. So in regards to the MMO for ages 6 to 18, this module provides norms categorized into three groups based on problem scores observed across different societies. So group one has norms for low problem scores, group two has norms for medium problem scores, and group three has norms for high problem scores. This classification allows users to select the norms most relevant for evaluating each child or youth, offering flexibility that can be very beneficial when working, for example, with immigrant and refugee populations. By choosing the appropriate normative group, clinicians can more accurately interpret assessment results in light of the child's cultural and societal background. The MMO 6 to 18 includes both syndrome scales and DSM-oriented scales, which ensures a more comprehensive assessment that aligns with culturally relevant standards. Similarly, the MMO for ages 18 to 59 provides a selection of norms based on low, group 1, medium, group 2, or high, group 3 scores, and includes US norms as well. And this module supports cross-norm comparisons for the ASR and ABCL assessments, and it covers a wide range of areas, including adaptive functioning, personal strengths, syndromes, DSM-oriented scales, internalizing, externalizing, and total problems. The availability of these multicultural norms allows for a more accurate and culturally sensitive interpretations of assessment data. And by facilitating comparisons across different normative groups, clinicians can identify whether an individual's scores are elevated relative to their cultural peers rather than relying solely on a single normative sample that may not reflect the individual's cultural context. In addition, there is also the Multicultural Family Assessment module, or MFAM for short, MFAM. I'm going to call it MFAM. The MFAM is a valuable tool that extends the utility of the ASEBA by providing a comprehensive family-wide perspective on behavioral and emotional functioning within diverse cultural contexts. The MFAM integrates data from multiple ASEBA forms, including the child behavior checklist, teacher's report form, youth self-report, and the adult self-report and adult behavior checklist. And by bringing together assessments for both children and adults within a family, the MFAM allows for meaningful comparisons between parent and child assessments. And this holistic approach is particularly useful for understanding dynamics within family systems and identifying areas where family interactions may influence individual behaviors. And yeah, one of the key areas of the MFAM is its use of visual bar graphs that enable side-by-side comparisons of family member scores. These graphs can be organized by age, gender, and society norms, making it easier to interpret the data within a multicultural framework. This visual representation helps clinicians and families alike to see patterns and variations in assessments across different family members, facilitating a deeper understanding of each individual's experiences and how they relate to one another. The MFAM is also designed to help parents understand variations in assessments, which can be super helpful in fostering strong therapeutic alliances. By involving parents in the assessment process and providing clear visual feedback, clinicians can promote greater collaboration and engagement in treatment planning. So this collaborative approach not only empowers parents, but also supports better outcomes for the entire family by addressing issues within the broader family context. Moving on to some trends and key findings from cultural studies incorporating the ASEBA, starting with research by Pace and colleagues in 2023. They examined internalizing and externalizing problems using the child behavior checklist and youth self-report. Their findings revealed that emotional and behavioral problems measured by the CBCL were generally higher, indicating that parents reported more issues in their children. In contrast, YSR scores were lower, suggesting that youth self-reported fewer problems than what parents observed. And one significant trend observed over the past 2 decades was that females reported more internalizing problems on the ASEBA than males, which mirrors epidemiological data. And they also found that age was correlated with increases in self-reported total problems and attention problems among older teenagers compared to younger adolescents. Interestingly, there was also a decrease in anxiety levels reported by this group, which could suggest that while overall perceived problems increase with age, anxiety specifically may decrease, possibly due to developing coping mechanisms or shifting concerns during adolescence. Cultural differences also emerged in the study, specifically in the manifestation of internalizing and externalizing problems. For example, they found a notable increase in internalizing problems such as anxiety and depression among Italian adolescents compared to Northern Europeans, which may be attributed to cultural norms around expressing personal distress or familial expectations. But more research needs to be done on cross-national studies. In regards to more cross-cultural comparisons, studies by Achenbach and colleagues in 2008 and 2019, as well as Salim and colleagues in 2023, have contributed significantly to our understanding of the ASEBA's applicability across cultures. They found that the core ASEBA syndromes have been validated in over 30 societies, demonstrating a remarkable level of cross-cultural consistency. And this validation supports the use of ASEBA tools in diverse cultural settings. In the context of the Arabic version of the ASEBA, moderate correlations were found between different informant scores. Specifically, the correlation between the CBCL and YSR was 0.54, and between the CBCL and TRF, it was 0.52. And these correlations are higher than the averages reported in 25 other societies, including Korea, Germany, Algeria, and Denmark, suggesting a stronger agreement among informants in these cultural contexts. And this could be due to cultural factors influencing how behaviors are perceived and reported by parents, teachers, and youths themselves. Moving on to some challenges and limitations, as highlighted by ZF and colleagues in their systematic review on the psychometric properties of the CBCL and YSR in sub-Saharan Africa. Poor or inaccurate translations can significantly distort the meaning of assessment items, leading to misunderstandings and invalid results. For example, the item sets fires may be misinterpreted in sub-Saharan African contexts where fire setting might be a common practice for everyday activities such as cooking, rather than an indicator of problematic rule-breaking behavior as it is in Western contexts. Additionally, inconsistent or undocumented translation processes can further reduce the validity of the assessments, as nuances in language and cultural expressions may not be adequately captured. Although ZF and colleagues found most studies use translated versions of the ASEBA forms, very few reported details on the translation and adaptation process, limiting the ability to fully evaluate the validity of the translation process. So poor translations of items that measure psychological constructs may therefore introduce bias, which may in turn compromise the validity and reliability of the scores on the ASEBA. Additionally, in relation to cultural and contextual barriers, studies by Achenbach and colleagues in 2019, Salim and colleagues in 2023, and again, ZF and colleagues in 2022 emphasize that the ASEBA forms are primarily designed within Western contexts. So this design may not align with how different cultures interpret behavior and emotion. For instance, many African languages do not have established terms to describe specific orders, emotions, or personality traits. And also, the example we talked about prior, the item sets fires. Certain behaviors considered problematic in one culture might be deemed normal or even positive in another. Moreover, rapidly changing societal dynamics and the presence of underrepresented subgroups may not be fully captured by the existing norms and scales. So this can lead to assessments that don't accurately reflect an individual's cultural background or current societal context. Another significant challenge is the presence of informant biases. Cultural perceptions greatly influence how behaviors are reported by parents, teachers, or the individuals themselves. And these biases can result in overreporting or underreporting of certain behaviors due to cultural stigmas or expectations, thereby affecting the reliability of the assessment. So given these challenges, it's really imperative to use the ASEBA with caution when working in multicultural settings. This means that the ASEBA should be employed alongside culturally sensitive methods to other culturally sensitive methods to ensure a fair and accurate assessment. Integrating additional tools, culturally appropriate tools, Seeking input from cultural informants or community leaders and being mindful of potential biases can enhance the validity of the assessment process. So last but not least, onto the strengths and weaknesses of the ASEBA. Starting with the strengths, the ASEBA is a valid and reliable assessment tool that has been extensively researched and validated across diverse settings. It covers a broad age range, allowing for assessments from childhood through adulthood, and incorporates multiple informants such as parents, teachers, and the individuals themselves. This is particularly a strength when assessing children and adolescents because it allows for the integration of diverse perspectives on the child's behavior and functioning. So by comparing scores across informants, clinicians can identify patterns, discrepancies, or unique insights from each perspective, resulting in a more thorough and reliable evaluation process. So this approach can really ensure greater accuracy and a more holistic understanding of the individual's strengths and challenges. Additionally, the ASEBA covers a wide range of psychopathology and adaptive functioning, enabling clinicians to evaluate numerous emotional and behavioral problems as well as the individual strengths. The availability of the ASEBA software also provides automated analysis, making scoring more efficient and perhaps reducing potential for human error. Additionally, the ASEBA is adaptable to diverse populations with translations and cultural adaptations available, making it suitable for use in various cultural contexts. Norms are based on extensive, diverse samples, ensuring statistical robustness and generalizability. And sample sizes often exceed 2,000 for specific populations, including various socioeconomic and cultural groups. However, given what we discussed in the previous slide, there are some weaknesses to consider. For one, although straightforward, completing the forms can take 15 to 25 minutes per form, which might feel burdensome for some respondents, especially for multi-informant use. I know that when I was filling it out, I was like, when is this over? So the assessments can be long and time consuming, which may lead to respondent fatigue and potentially impact the quality of the responses. There's also a cost associated with the ASEBA. A lot of the literature pose this as a strength, but it may be a barrier for some practitioners or institutions with limited resources. Additionally, the inclusion of collateral information from multiple informants is a strength. However, when different informants endorse varying levels of symptoms or even opposing views on an issue, how to interpret this information can become tricky. One might be tempted to favor self-report as more accurate and disregard the caregiver information, or find the parent more trustworthy and ignore what the teen has to say on the other hand. Neither of these decisions would be optimal, and we can't replace the information from one informant with data from another informant because observations about a single person can vary greatly based on the situational context. Furthermore, the ASEBA aligns with DSM categories, but it does not include all criteria for many DSM diagnostic categories. And although DSM-oriented scales are scored from ASEBA instruments, users are cautioned that high scores on these scales are not directly equivalent to DSM diagnoses. Instead, users need to consult the DSM for precise criteria for each disorder and then determine whether clients meet all criteria. And lastly, the ASEBA may be limited in assessing subtle cultural nuances, potentially overlooking culturally specific expressions of psychopathology or adaptive behaviors not captured by these standardized items. So in conclusion, the ASEBA is a powerful, comprehensive assessment tool with significant strengths in providing reliable data across a wide age range and from multiple informants. However, it's super important to be mindful of its limitations.